It's too large. L1 is too large, I'm afraid. Okay. But not completely.
Good morning, Dr. Saito.
Good morning.
Maybe before you get started, you want to tell us about what's the general strategy?
Okay. Anyway, I think for this particular patient, maybe after watching the cine, I understood that the only antegrade approach is feasible. So first, I took the unplugged left with side hole. Unfortunately, we did not have any 7 French system for this shape. So I'm taking a 6 French guiding catheter with side hole.
AL1.
AL1. However, the engagement is not complete. So, okay, this one. Shall we take a picture? I don't know whether there is a microchannel or not. But anyway, always I'm taking the microcatheter. Microcatheter, yes.
And wire?
Wire is XTA.
XTA.
So by selecting the XTA, you're going to try to find that micro channel?
Yes.
Okay, yes.
Microcatheter first.
Microcatheter? Which microcatheter? This is
Asahi. 135 Asahi.
Corsair.
Yeah.
Ah, okay.
It's okay for you? This one?
So this time I'm taking a Corsair microcatheter.
Okay.
And any special reason why you're selecting the Corsair?
Corsair, of course, we can choose the regular microcatheter instead of Corsair, but anyway, I don't have any good reason to choose this microcatheter. So you can take regular microcatheter as well. Okay, I'm making a very short bend, maybe 30 degree or 45 degree. And also 3 or 4 millimeter proximal from the tip of the wire. I'm bending a second bend, making a second bend. That is 10 degree, 20 degree. Okay?
That's a beautiful demonstration there. Thank you for that.
Coming? Not yet.
No, not yet. Okay.
Okay, coming. you can see the microcatheter. Oh. Test. Okay. Okay. I put the tip of the wire into the right coronary artery, and then while keeping the wire in this position, I'm pushing the microcatheter. Okay, microcatheter is going in. Okay. Yeah. Even I was pushing the microcatheter, the tip, and also pushing the wire. The tip of the wire is bending. So that's why I push the microcatheter more deeply to support the wire, and then try to push the wire. The region is tight, hard. Can you make it closer?
Closer.
TV screen is
Yeah,
far.
yeah. Bend. Okay. Okay. Okay.
Okay, shall we take a picture? I think the tip direction at this moment is okay. But the problem is because the occlusion site is too hard, so the wire is bending. So maybe I will try a little bit more, and I also make the tip of the microcatheter further, a little bit further. Okay, I advanced.
So that adds to the gram tip of the wire here. Gives you more
Okay,
support.
then I try to push the wire again. No, I think the wire is too soft for this occlusion. So maybe I have to change the wire selection. Maybe, can I have Gaia first?
Gaia fast.
Yeah, impossible.
Maybe you can tell us your thoughts about Gaia Fast. What's the reason for that?
Yes, because this wire is too soft for this occlusion. So that is situation is a time for me to change the wire selection to stiffer one. The first stiffer one is Gaia Fast. Okay. Just a
Remote.
moment. Yeah. Not yet.
Not yet. Yes.
Okay, wire is coming.
Professor Saito, any reason that you don't want to escalate directly to Gaia 2 or Gaia next 3 rather than take Gaia 1?
Yes, I want to take the strategy of stepping up. So I think, again, this wire is too soft. Okay, take cine. Very difficult. One more injection. Oh, sorry. I cannot see anything. Maybe we have to make a contralateral.
Contralateral.
Okay.
So I asked to make a contralateral route.
Sanjay Bhai.
Might be, might be, but I'm not sure. I want to see.
No. સારો હું છું પંચા કરી દઈશ 5 ફ્રેન્ચ હું કરી દઈશ હું પંચા કરી દઈશ લેફ્ટ સાઈડ 5 ફ્રેન્ચ 5 પેનની સીટ
Rajiv, I don't know, can you hear me okay?
Yeah, we got great audio here.
Yeah, so as you probably gathered, they're now setting up for contralateral injections here. And so I think you've got a few minutes maybe to engage the panelists there in a discussion. Looks as though he's actually in the vessel, maybe that RV branch perhaps, but
That was the feeling over here that
Yeah.
maybe there's a little right ventricular.
Dr. Saito said he just can't see anything, obviously. But as I said, we've just got a few minutes for panel discussion.
small branch
There were collaterals from the proximal part
right
of
about
RC.
RV branch.
Homo-arterial collaterals were seen.
Maybe.
So can we go back to the first scene, Dr. Rajni?
hello
Dr. Rajni, I'm Tarun from panel.
hello
So we are going to take the left radial, or
yes
are you telling
left
the femoral?
left
Yeah.
radial
It's left radial.
And this will be a diagnostic catheter only. We're not planning a, is that correct? Just a diagnostic catheter on the left?
Dr. Saito,
Yes.
this is going to be diagnostic catheter from the left,
Yeah,
or
yeah,
guiding
diagnostic.
catheter?
Di-
No, just
diagnostic.
purely
diagnostic
diagnostic.
5 French
5 French diagnostic.
So can you show the angiogram, our first angiogram which showed the bridging
Yes.
collaterals as Dr. Tarun was mentioning?
Yeah, those angiograms are also 1 month old.
Hardik
So it looks like something has
Hardik
changed.
can you show the angiogram
Those were 1 month old pictures, right?
I'll try to find these for you.
sir RCA suit
Cannot see. You can see RCA?
yeah
Huh? Really?
let's see this
Yes.
So from
Yeah,
epicranial
but,
LED is not giving any collaterals to RCA.
Antegrade
Yeah, but
flow.
I think
Yeah,
because,
antegrade.
because there was bridging
you must be
collaterals
in
at
the
that
right
time, but
RA
now that we
branch.
don't see
This
those.
Yeah,
RBC.
probably
Yes.
now the LED might have been.
The angle
Right.
from
Yeah.
there is very acute.
this junction
Yeah, it's very acute. So
While you're getting the other side ready, just a question from here about the use of side holes in the catheter. Was this specifically because of osteal disease, or is that a routine thing for Dr. Saito to use for CTO?
Were you able to see enough of those first images?
Yeah, we saw them beautiful. We know that they were a month ago, I think, so a fairly significant change since. Yeah, they're up now.
Dr. Rajiv, that you mentioned use of side-hole catheter. I mean, how much false sense of security it can give at times if you have a bad osteal lesion?
Personally, I think exactly what you said. I think it's a false sense of security. I'd rather know that my catheter is jamming the ostium rather than have side holes. Now, the opposite argument of this is the side holes will give you some flow, and that would help, reduce the ischemia during your, the catheter dwell inside the ostium. But I think it can also be deceiving, and you don't pay attention. And the amount of flow that goes through the side holes, I can't imagine is that much anyway. So it's probably better to know and to try to do something about the position of your catheter rather than just keep going with a good pressure tracing.
I agree.
So any osteal RCA cases, if you want to do, it's always better to put another wire in the cusp so that it will prevent the catheter-directed injury to the ostium of the RCA.
True.
It looks as though this left radial artery access is going to be a bit more challenging than they thought.
Because this is TRICO, just to raise and continue talking about the radial access. Suppose the radials are not easily accessible on the left side, you would go ahead with the femorals or the left ulnar?
Well, I saw Dr. Saito feeling the femoral pulse a moment ago.
110. Happy.
But what is your opinion? What's your practice? Owner?
So if it's a virgin radial or virgin ulnar, we do take ulnars. But if it's a single artery, like if the left radial has been harvested for a bypass graft or has already undergone a puncture, then of course that's one of the time when the Barbio test or the Allens come in, and then only we puncture the ulnar. But there have been case reports that we have had a failed puncture of radials and still in the same limb we have accessed the ulnars and nothing happens. Dr. Tejas often talks about the introitious, the missing third, which actually salvages the limb, not the radials and the ulnars.
Sasko, who's been here to this meeting, has published a lot on ulnar access. We've got Sam Panchori. Sam, have you got any sort of wise words about ulnar after a failed radial access on the table?
Yeah, I think it could be done clearly. Macedonia has quite a large experience in it. But again, it's all depending on the patient population. So those were mostly young smokers with STEMI and probably not as extensive disease as we see here in India or in my practice. We have Dr. Babunashvili in the room, and he probably can tell you more about intra-RCA than anybody in this faculty. So I think we have to look at the patient's burden of disease. I would not try it here because there's probably extensive peripheral disease.
Well, the The discussion is a little hypothetical now because they have access. But certainly in my experience, you know, if a failed radial and it's a good owner, that's...
left ulnar is.
So this was left owner. Yeah. So there we go. So failed radial and then successful owner.
So, you go. પછી મૂકી દેજો.
This is going down.
Yeah. Go, sir. LAO, entry mode.
Can we switch to the live angio screen now? Thank you.
No, this is...
Go.
Staying hypothetical till we get real, just in case we don't see any collaterals from the left. Any plans to have IVUS imaging to cross the CTO?
Nothing. Very difficult anatomy.
I think this is a nice demonstration of why we do not like coming from the left arm with these catheters.
No.
Just so. Five French Ibu.
Yeah, so I think Dr. Rajni mentioned it clearly. 5 French Ibu is something that does better job than Tigers from the left arm than the right. This is Tiger. Diagnostic.
Okay.
Okay.
Chalo.
Have the guides, have the catheters got entangled, or it's just an image?
Epicranial.
LAO.
LAO.
Yeah, I think this answers your question.
Okay.
Una piece. Long short.
Okay. RAO.
Areo.
Yeah, so that's a good teaching point here, because the two angiograms are 1 month apart, and at the time of the first shot of the RCA that we saw earlier, the LED was also heavily diseased. So now the LED is open and it's been a month. So what
That's
happened is the
separation.
collateral circulation shifted from right to right. Now it's more left to right. So
I think
this
is
angiogram
not
now
RB
becomes
brand.
really helpful.
Somewhere else.
The contralateral
Yeah.
angiogram becomes really helpful in identifying the distal
No,
target,
I don't.
as
No.
opposed to
No,
1 month ago when it wasn't that useful.
LAO.
No, this one. This
Same
one.
view.
Put this image too.
Say freeze.
Store. Okay.
Same.
Okay.
So Dr. Saito, you think you're in an RV branch?
No.
Oh, yeah. Okay.
Okay, LAO. Can I have XTA?
XTA.
It's yes.
Remove it.
Just a moment. Okay, remove. Zoom should be zoom.
Zoom.
Difficult. Okay. 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 Inject both. Okay.
Okay.
You first.
Yeah.
Okay. Go.
It came out.
Ah.
It came out. I engaged. PA. वो आप ही दे. Ibu.
And RCA was out.
Hello.
So the idea of changing back to Fielder XTA was that you had already pierced the proximal cap, and that you thought maybe because the wire was in one of the branches, you could just manipulate through and actually enter the distal cap as well through the Fielder XTA, right, Dr. Saito?
Yeah. But anyway, the RCA was out.
PA.
LAO.
Hello. Just check it. Okay.
difficult. Maybe can I have a JR 3.5?
JR 3.5 side hole.
No,
No,
not
regular one.
Regular. No, cannot. No, this is too long. No. JR.
Okay, change.
Change.
Remove this.
JR 3.5. Okay. This is guiding catheter?
Yeah.
Okay. Okay. Test. Test. No? The guiding catheter engagement is also very difficult.
Oh, it's little proximal. Yeah.
The engagement is not perfect.
Yeah.
It's unstable.
Do you guys have MAC 3.0, 3.5, MAC?
3.5. This is not good. Quite unstable. No. Any other guiding catheter?
We do guiding AR.
AR?
AR1.
But no backup.
AL 0.75 or AR maybe?
0.75, we don't have. Maybe.
We don't have 0.75.
No. We have only AL1.
Can we try the microcatheter?
Yeah. Okay. Put microcatheter.
Microcatheter. wire. With wire?
Mm.
With wire. Feeder.
No good collateral. No good collateral.
Yes, we are in RCA. Go with the microcatheter.
Yeah, but you're keeping the wire.
Yes.
Quite unstable. I'm pushing the microcatheter.
Go.
No. If I
I strap the wire.
not yet. I'm pushing a microcatheter slowly. Not yet.
Yes.
Okay, coming.
Yeah. Yes.
Okay, coming. The tip of the microcatheter is going in.
Okay. Okay.
Okay, here.
Yeah.
So shall we take contralateral angiography?
Fluoro. Both sides?
Just move.
Yeah, Ravel.
So you first.
Yeah.
Okay, go. Okay, I'm trying to push the wire. Can you shift this one?
Freeze. Okay, switch.
Very hard here.
Yeah.
Which branch? Anchoring?
No.
Yes, but that conus branch is a little bit short.
Going straight.
No. Test. This is the outside. Yeah. This is the outside.
No.
I think the wire is going outside. Any good idea you have?
Try crossing in RA view.
I think the difficulty in this patient is guide catheter seating is not perfect. And the guiding catheter engagement are also very difficult for this patient, for left coronary artery and right coronary artery.
Can you please bypass
Any
first
utility
previous
here
one?
maybe to parallel wiring, Dr. Sato?
Pardon?
Parallel wiring?
Parallel wiring? No, but anyway, the guiding catheter position is not stable.
How about a guide extension into the proximal RCA?
But there is some narrowing. It might be very difficult to put the guide extension. So take the guide extension, maybe.
Yeah, not
Open.
one. Guiding extension.
Okay, I'll try the guide extension, but the maneuverability of this system will not be good. So
Remove.
remove. Can you keep the wire?
Okay. Implantation device. Oh no. चल 10 maintain 10 maintain 10
Okay.
okay 10
Oh,
oh
out.
it's okay
No, out.
very enter not okay
This is fine. Test, please. Test. Okay. So, guide extension. I think I'm afraid that the guide extension is bulky. So, I'm afraid the insertion of this guide extension into the proximal right coronary artery may break the structure of RCA. Cannot get in. Yeah. No, because of some narrowing in the proximal RCA, I cannot push the guide extension into the right coronary artery. Okay? No. Difficult situation.
Yeah.
This doesn't work.
Remove this.
Or put the microcatheter here.
Oh.
Here. I will place the microcatheter. No? Okay. Cannot. You don't have a wire extension.
No, we don't.
No.
Sir, can we try crossing in RAU view? You can see the straight pathway of the calcium from where to go across.
Remove this.
Remove?
Yeah. Okay. We go microcatheter till the tip.
Yeah.
Then we give the wire inside. Is another choice.
Yeah. But wire is out.
The Pachati wire.
Is it possible that if you get access from the femoral artery, you can use the AL1 again? Would that be more stable?
I don't know. Do you think so?
Go. Okay. Somewhere else. Scout. Okay.
So then I will try to push the extension catheter, but cannot do it. Everything is going out. Okay. So maybe takes in. Okay. Okay. Can I have Gaia third or fourth?
Gaia second, fourth.
Fourth. You have?
Gaia first.
Fourth.
Previous one. So the tip, I think.
Previous one is Gaia first.
Yeah.
Gaia first. No. Gaia's third or fourth?
But Gaia
Third. Three.
Gaia 3.
Gaia 3 or 4?
3 or second, both we have.
Yeah, okay. This one. Okay. How about RL? catheter is not good. Can you take control?
Hello. Hello. Wait.
Hello. Okay. I'm not sure.
So there was an upper branch there. I think you're in the branch. It looks like true lumen so far.
Really? I don't think
Yeah, there
so.
were two branches. I think the distal we are seeing, the proximal is where your wire is. If you can look at the previous angiogram, the first angiogram done a month back, you just need to probably flip it and this is probably the second one. This is the second branch, if we can have it. Guide support is an issue. Maybe otherwise imaging would have helped you out.
I think this one is not in the true lumen. One more? Okay.
Same. Same place.
Same space, but not in the true lumen.
Not in the true lumen.
And we don't have any good collateral from contralateral LCA, no connection. And also the most difficulty is engage.
I know.
So how do you think? Yeah, okay. Just, okay, 5 minutes.
No problem. No problem. Absolutely no.
same.
Same.
Same. Very hard.
Yeah.
No,
No,
no, same space. Yeah. Okay, I'm sorry, I have to stop. Okay.
It was such a wonderful demonstration, you know, and we all know that he's a world authority as far as, you know, this particular subset, the most difficult subset of coronary intervention is concerned. And a lot of lessons to learn. Malcolm, if you want to comment.
I think the only comment here is, in addition to that, is just the enormous concentration that was required here. This room was very silent, and I think in these cases, when you have a master like that, Saito, we just have to let him focus.
Thank you. My pleasure. Thank you. Thank you. Thank you for your good comment. Thank you.
Remove this one.
Thank you.
Yeah, we would like to thank you, Dr. Saito, and the team as well. Even though the outcome wasn't what we expected, but we learned a lot from the